So I want to talk about something that's just kind of a stressful situation, at least for emergency medicine doctors here in the United States. It's going to be kind of a brief overview of a topic that you guys might be slightly more familiar with than I might even be, considering they deliver babies. We're just going to talk about obstetric care and obstetric emergencies. Um, just give kind of a brief overview of kind of the approach to sick pregnant patients. These types of patients don't occur frequently in the United States. Um, we're going to talk a little bit about common emergencies and common approaches to things, and then a little bit about international and US guidelines in terms of management of the potential obstetric complications that can occur. Okay. Um, After this, we'll have a little bit of a discussion. Uh, the next two sessions will be mostly uh, the next session will be a preparation session for an in-person session that we can hopefully do later in August. And I'm going to organize that with Dr. Clement in terms of what we end up doing. But today we're talking about obstetrics. So let's begin. So the case that I wanted to talk about was actually an uncomplicated spontaneous vaginal delivery that a multiparous woman had outside of the hospital. She was picked up in a rural area and was actually transported to us via helicopter. Not necessarily because she had anything concerning, but just because she lived extremely rurally. She had not delivered the placenta. EMS was very concerned. They had minimal bleeding. The medics gave TXA. Um, on arrival, the umbilical cord was hanging out of the vaginal androides, and vitals were normal. Um, Mom was comfortable. Uh, so this is just kind of a very brief intro to a case about a bunch of EMS and pre-hospital staff who were uncomfortable with vaginal delivery. A couple learning objectives. We're going to discuss kind of how pregnancy affects physiology and anatomy. What are the specific emerging conditions that we have to look for? We'll talk a little bit more about third trimester pregnancy. Specifically, we're not going to talk at all about ectopic pregnancy or any early pregnancy complications. This is for women who have a gravid uterus. We're going to talk about bleeding. We're going to talk about infection because those are extremely common. And we'll talk a little bit about point of care ultrasound, um, kind of in relation to how important it can be. Um, so the one of the things that has been a humongous focus on modern medicine and quality improvement has been maternal morbidity. Mothers historically have been very susceptible to death by postpartum hemorrhage and maternal sepsis. Um, we know that improving access to care has truly decreased this and directly impacted maternal mortality. From retrospective data in the United States, a country that thinks that they're doing it right, it showed that up to 60% of maternal deaths have been from quote unquote preventable causes. We don't even do it right. There are very few places that really have it down. Several countries in Europe that have very, very low maternal morbidity mortality rates. But it's an area of medicine that keeps obstetrics in business. And it's also something that has been shown multiple times to improve multidisciplinary care. As doctors, as providers, as clinical officers, you all and we all have the responsibility and duty to try to educate the faculty and the staff that take care of patients. It's our duty to make sure that everybody's in the same boat. Some of this stuff might seem very, very simple when it comes to maternal fetal medicine, but a lot of it just comes down to actually reinforcing what's important to entire team and making sure that there is a multidisciplinary approach in terms of trying to make sure that all team members are on the um, same boat. Um, there's a 61% decline in global deaths. Uh, there's been reduction in hospital morbidity, mortality. Most of this is attributed to contraceptives and skilled birth attendants, i.e., the lack of home births. I don't know how common home births are in Tanzania. I didn't work in L&D when I was over there, but I'm curious how often that does happen. We know that the leading causes are sepsis and hemorrhage. So, a little bit about anatomy and pregnancy. Pregnancy creates increased intra-abdominal pressure. By creating the increased abdominal pressure, it creates decreased space in the chest, lower tidal volumes, increasing the respiratory rate and decreasing the the total functional vital capacity. By doing that, your moms have to breathe a little bit faster in order to keep up with minute ventilations. In fact, minute ventilations are usually a little bit elevated in order to compensate for the fetal metabolism. Um, so that's the first thing that happens. The second thing that happens is that it decreases the potential cardiac return in the great vessels. And this becomes very important when moms lay down supine. If they do lay down supine, it compresses the vessels and can decrease cardiac return, creating kind of obstructive shock physiology. We know from like physiological studies done in labs that about 30% of the returning cardiac output can actually be decreased if mom's laying back on her back. So if you have a patient who's hemodynamically unstable, this becomes very clinically applicable. And you want to make sure that mom is actually lying on her side, if at all, kind of in kind of a oblique stance, in order to kind of allow you to take care of the patient, but also to allow offloading of the great vessels. Um, so, what consequences does the anatomy or what consequences in physiology does the pregnancy impose? Um, there is significantly more plasma volume in mothers who have pregnancy. It increases by about a liter or two. Because of this, there's more circulating GFR. Kidneys have to work harder. There's more clotting factors. And like I mentioned, there's more hyperventilation. And there's an alkalosis that you can see in pregnancy. There's a number of different laboratory values that you need to know when taking care of a mother. Although a normal PA CO2 for a walking, talking adult is otherwise 28 to 32 for a venous blood gas. In pregnancy, it can be normal for a mom to have as high as 40, something that's actually mentioned in a upcoming slide. In order to in order to compensate for the increase metabolism and minute ventilation, cardiac output also increases. Um, and the metabolism that mom has also usually causes increases in fetal demand, fat deposition. Um, and because of this, also creates insulin resistance that we see causes hypertension, diabetes. Now, this is all medicine that I learned back in medical school. This is not necessarily medicine that I think about frequently as an ER doctor, only when taking care of pregnant patients through the emergency department. What we do know, though, is that, the most important thing is to remember that they have increased clotting factors, increased insulin resistance, and increased plasma volume. Um, the reasons to remember this is that they're not necessarily volume responsive. They're at higher risk for potential clots or VTEs. And a blood sugar goes a long ways in terms of management and acute care. So, when you have somebody who is pregnant and you're trying to do critical care, you have to remember the couple things that we just talked about. The circulating volume has changed. The patient's vascular tone is affected, usually. They're at an increase in clotting. Um, and ventilation is significantly different than in somebody who doesn't otherwise have a gravid uterus. So they're less volume responsive. Usually, the main historical feature to grab during care of an obstetric patient is to make sure that you're evaluating for bleeding. If there is no historical features of bleeding, then an infection should be presumed as potential shock state. Um, Usually, I do this with a pelvic exam and an ultrasound. Um, This is just because, there are two ways that a mother can bleed. They can bleed externally through their cervix, or they can bleed into their abdomen. It's more rare for them to bleed into their abdomen, but this is usually the general workup. Um, we'll talk a little bit about this next month, but the other thing that is important in terms of point of care ultrasound for care of a patient who's sick is also evaluating the heart and the inferior vena cava, which will be affected in pregnancy, but will allow you to kind of assess volume status and determine kind of what next steps need to be done in terms of resuscitation. Um, if you're concerned about volume loss and you're concerned about hypovolemia, replete until you feel like you've repleted enough. Um, and then because infection is the second most common cause, if there's no history of bleeding, then I'd recommend starting, peripheral vasopressors, dopamine or norepinephrine, whatever you might have available at your shop. If God forbid you ever have to intubate these patients, you have to remember that there's going to be decreased compliance. I don't think we've ever had a talk about ventilation, but ventilating an obstetric patient can be tough, especially if they have underlying pulmonary disease. So you want to target a higher minute ventilation than you otherwise expect for a patient their size due to the increased metabolic demand, which we've already talked about. We want to do this by targeting respiratory rate rather than targeting tidal volume. The patient won't be able to necessarily hold very much tidal volume due to um, the gravid uterus, and because of this, gas exchange can be kind of difficult. Um, so respiratory rate that's a little bit higher is going to go a long ways. Um, Most guidelines and US guidelines suggest an SpO2 of 95%, at least for laboring mothers. If you're checking on a mom routine prenatal visit, it doesn't necessarily have to be this high, but usually if they're critically ill, they need a higher SpO2, and that's more for the baby than for the patient. So, um, when you take care of a sick patient and you're concerned about the potential that, being pregnant has, we got to consider hemorrhage. Hemorrhage is number one and number two on the list, and then sepsis is number three. Um, there are physiological changes to pregnancy, um, and we know this, so we want to make sure that, things are considered in terms of airway breathing and circulation, but circulation is always usually the thing that is considered the first when taking care of mothers because hemorrhage is so common. One thing to consider about kind of the primary survey, though, is that airways are statistically more difficult in pregnant patients. Um, this is just because of the changes in pregnancy that can occur. Um, Moms just tend to have a little bit more anterior airways, and this is because of increased fat deposition. It can be because of multiple different obstetric things that I couldn't necessarily attribute to, but I think one of them is fat deposition, and then also just the decreased chest compliance that occurs in pregnancy. Um, but about 1 in 200 airways are difficult in pregnant patients, which is a little bit higher than the walking, talking, um, non-obstetric population. I usually reach for a fast exam very quickly for patients, even if there's absent of trauma, but especially in trauma. Usually the indication for a fast exam, and again, we'll talk about this next month, is a patient who is hypotensive in the setting of trauma. I will almost always do one for pregnant patients, mostly because I'm also just trying to check on baby and make sure that the baby is healthy as well, and to grab fetal heart tones. One thing that's also very important, and something that we've kind of just glanced over, but also is important, is that if the patient arrives in the supine position, and they are hypotensive, there's a maneuver to laterally displace the uterus, in order to adequately do chest compressions. Um, I also would recommend doing this if mom is sick or if you have a systolic blood pressure of less than 90. Uh, this is this is just to make sure that the baby is offloaded off the IVC. If the baby is compressing the IVC, then you will get an obstructive shock type picture. And it's extremely important to try to kind of remember that. And if mom looks like she's pregnant and she has a gravid uterus, then you want to laterally displace the uterus off the muscles. Um, One other thing that data shows constantly is that early TXA has been shown to be effective in hemodynamically unstable patients. Sorry, this is not supposed to just say stable, unstable patients. Um, and this is just because usually hemorrhage is the thing that is most concerned. Uh, and in a patient who arrives who is hemodynamically unstable, who then subsequently develops pulselessness, if you need to do chest compressions, there's a procedure that we are trained in emergency medicine in the United States called a resuscitative hysterotomy. Usually, the indication for doing this is within 5 minutes. It shouldn't impede chest compressions, and the patient should be laterally kind of placed in that lateral incline in order to allow you to offload the great vessels. Um, I've never had to do one. They're very rare, but on the off chance that it does need to be done, it should be done kind of within 60 seconds by somebody who is trained. I know you all do C-sections regularly, so you all know how to make a laparotomy incision and deliver the baby. The difference between this is that you're trying to save baby and trying to save mom. In some of the studies, when done appropriately, resuscitative hysterotomy uh, can actually improve maternal morbidity and fetal morbidity, to the point where 50-50% chance of actually saving both mom and baby, by actually delivering baby immediately. So that, and assuming regular care, epinephrine for mom, standard prenatal care for baby, or perinatal neonatal care for baby. Um, we talked a little bit about how to vent a patient, but this is just a little bit more. So the main thing to consider when you're doing a primary survey on a patient who's pregnant is that fetal heart tones are included. This is why I usually recommend kind of liberal use of the fast exam, because in my exam in the United States, if I see obstetric as part of the presenting thing, it's one of the few complaints that I'll take the ultrasound in with myself for the initial evaluation, just to try to make sure that I can get a clear examination of both baby and mom. but also to make sure that I can get the fetal heart tones as a part of the primary survey. Um, the secondary survey is the extensions that usually just include a pelvic exam. Um, really, in addition to any type of ultrasound of the complaint. Um, and again, we're not talking about all use of ultrasound here and during this lecture, but for those who are interested, we will be talking more about this in the future, both next month and the upcoming month. Um, the pelvic exam is extremely important, both to make sure that you rule out labor, but also to make sure that you're not seeing any type of trauma or vaginal bleeding. Really, external vaginal bleeding is the thing that's most concerning. Um, and it should be considered kind of a uh, essential part of the secondary survey. So, what are the conditions that we want to have special considerations for? It's really kind of an exhaustive list. And when you talk about acute care, I know we've talked about encephalopathy before, and the list has been, multiple pages long. In pregnancy, there's really kind of four things that you kind of have to think about. Eclampsia and their associated syndromes, the hypertension syndromes of pregnancy, if you will. Eclampsia is a systolic blood pressure over 60 or over 160, systolic or diastolic over 110, with associated seizures and proteinuria. It is a medical and obstetric emergency. All of these are treated with delivery of the baby. The obstructive shock that we've already kind of talked about and emphasized that can occur when you have mom in a supine position. And then the most common cause, excuse me, the most common cause of maternal and fetal morbidity is hemorrhagic shock. Um, the specific considerations in regards to that are, placental abruption, placental previa, vasa previa, and uterine rupture. I don't usually do a digital exam in the emergency department unless I know where the patient's placenta is and I can see it adequately. Same thing for vasa previa. Placenta previa is where the placenta has a specific area over the endocervix, allowing for bleeding of the placental blood. Vasa previa is a little bit different. It's an umbilical abnormality where the baby's blood is actually at risk. And it is specifically placental blood that is coming out of the umbilical cord. So if you have bleeding from vasa previa, it actually leads to fetal morbidity. Placenta previa is mom's blood. Uterine rupture, which also happens frequently in the United States, mostly because of drug use, but also because of prior cesarean sections. Usually, we don't let moms labor for this reason. And prior cesarean section is usually an indication to defer labor and actually skip right to C-section because of the high risk of uterine rupture. It's not extremely high. I think it's only as high as like maybe 1 to 2%. But if you let moms labor long enough with a history of a cesarean section scar, they're at risk for uterine rupture. I've seen this once or twice. The risk factors for abruption or drug use. And the last thing that we'll talk very briefly about is cardiac comorbidity. Cardiac comorbidity just occurs from really two things. The increased clotting factor, which can increase the risk of pulmonary embolism, but also the increased incidence of something that's relatively rare, but I have seen before, amniotic fluid embolism, as well as cardiomyopathy. Um, I don't know about incidences in epidemiology in Tanzania, but usually cardiomyopathy occurs for patients who have one or two potential conditions, i.e., very bad luck, is the first risk factor, usually associated with just poor pregnancy and hypertension disorders, or pre-existing drug use for moms who have used stimulants like methamphetamine or cocaine. We're going to talk very briefly about each one of these. So, postpartum hemorrhage, what's the definition? The definition is moms are at risk if they've lost half a liter. Once they have lost about a liter, this meets diagnostic criteria. Um, Usually how they do it in L&D and how I try to actually mimic the practice is by weighing pads. Usually what we will do is we'll take a small fetal scale. One of the scales that can actually weigh babies is usually sufficient. See how much pads actually weigh. And then you weigh them after the bleeding in order to kind of gather how much bleeding has occurred. This is just because after you've lost so much blood, it can kind of be hard to actually keep track. In American delivery rooms, usually they have multiple layers of pads or multiple layers of like hemostatic devices or gauze, and then they'll weigh whatever they feel like they've actually noted saturating, um, and then they'll compare it to whatever the dry weight is for those specific tamponade things. And then they'll compare it and see kind of how much, a gram of blood or a milliliter of blood weighs about a gram. So you can do the math pretty quickly and figure out how much mom has bled. The first management strategy for postpartum hemorrhage, and this looks like it's reflected in most of the WHO international guidelines as well as the US ACOG guidelines, is fundal massage. Um, if mom looks like she's bleeding enough that you're concerned about postpartum hemorrhage, you want to make sure that fundal massage is the first thing that's done. There are two ways to do this, and I have a couple little slides accurately representing how. Um, I don't do the bimanual massage because I feel like it's outside my practice if I ever feel like I need to. But it's something that can be done where you stick a fist into the woman's vagina and then put a little bit of pressure on the actual uterus. A much more common approach is to just put firm pressure at the top of the uterus, grab the gravid portions of the uterus, and then just press firmly in order to try to get tamponade. If this doesn't work or mom is persistently bleeding, um, and usually because postpartum hemorrhage is very common, oxytocin is given as the first line. Uh, Again, I did not rotate or work at the labor and delivery department in Tanzania, so I don't know what you guys end up doing. Most of the guidelines suggest that 10 international units given IV is kind of standard of care. I have seen it in the United States where they give it IM as well. Um, Adjuncts for this are methylorgonavine and carboprost, as well as if you're concerned about patients who are at risk and or who meet diagnostic criteria, then there's signal benefit for patients who have TXA. Um, so there's also this mnemonic of the T's of primary or postpartum hemorrhage or PPH. That's tissue, trauma, tone, thrombin. You can't do much about, thrombin, but you can do a lot about tone. Um, Trauma is kind of obvious. You control any bleeding or any lacerations in the perineum that mom might have. And then you want to make sure that you deliver all the tissue if you feel like you need to. Kind of manually evacuate the uterus. And if you do, then you want to make sure that the patient gets antibiotics for endometriosis concerns or endometritis concerns. So if mom still has bleeding after this, it's a stressful situation. Usually what's indicated in the United States is a tamponade device, something called a Bakri balloon, which I'll show you a picture of. It's a balloon that kind of mimics a Foley catheter, goes through the cervix, and can blow up with about 200 cc's of fluid in order to tamponade the uterus. If you do this, it's also kind of recommended that you place a little bit of downward pressure and or try to kind of provide a little bit of uterine massage to the tamponade device. If you're doing this step, then it's likely that you should have probably done all of these things as well. So don't ever place a Valkyrie balloon if you haven't already given at least oxytocin and TXA, if not carboprost and methylorganovine, if available. This is getting to the point where this is a medical emergency, and the postpartum hemorrhage is possibly life-threatening. Um, if tamponade is needed, you should also be considering giving blood. Um, in the United States, if the tamponade device is unsuccessful, then interventional radiology usually gets involved for uterine artery embolization. There are other algorithms that also talk about hysterectomy. I'm sure that an obstetrician consultant at this point would probably be involved in a PPH that is this severe. So maternal sepsis is the second leading cause in maternal death after bleeding. It usually has a late presentation. Sources usually include chorioamnionitis, endometritis, and pneumonia. That makes up for about 3/4 of all actual illnesses, or just under 70%. Um, it's something to consider. Um, the surviving sepsis guidelines, which we have talked about before, recommend that, in severe sepsis or in septic shock, antibiotics should be given within 1 hour of suspicion, um, or 3 hours of suspicion if the case is unclear. Usually the most important vital sign in pregnancy is blood pressure. I will say kind of a full set of vital signs and an adequate clinical exam should be done. Also, the risk factors for infection should be kind of assumed. Infection usually kind of starts at day 3 to 5 postpartum. Um, Remember that, other things when you're taking care of a laboring patient can cause fever. Um, when you're talking about antibiotics, specifically ordering antibiotics, you want to remember that beta-lactams are the first line therapy. Most guidelines suggest ceftriaxone or third generation cephalosporin. Um, that's usually what we use here in the United States, or cefuroxime is one of the other ones. There are a lot of differences in how additional antibiotics are added. I'm sure in Tanzania there's a pretty liberal use of azithromycin. There is that one paper that showed maternal benefit with the dose of azithromycin for labor. Some of the international and WHO guidelines actually recommend ceftriaxone and metronidazole as first-line therapy, specifically for maternal sepsis, not necessarily for any like peripartum complications. What I would remember though is, you know, the third generation cephalosporin, metronidazole, and azithromycin are kind of the most hopeful um, antibiotics, specifically for moms in the peripartum period. With maternal sepsis, because of higher circulating volumes for mother, usually the guidelines only suggest 1 to 2 liters rather than your conventional 30 cc per kilo bolus, specifically in sepsis. And the reason why is just because mom has higher circulating volume, she can be less volume responsive. So usually, if you feel like mom needs volume, it's usually blood and not actual fluid. So a restrictive fluid strategy has been suggested in guidelines. The grading of that evidence is pretty low, and we don't necessarily know how certain, that might be. use your clinical judgment if you feel like there's hypovolemia from, insensible losses or dehydration, and you can also just replete as needed. A lot of the guidelines also suggest about uh, venous thrombolus, venous thromboembolism, and stress ulcer prophylaxis, specifically for patients who are septic and critically ill. I don't know how often you guys are doing that in Tanzania. It is done in the United States, not infrequently. So, well, second to last, the hypertension disorders of pregnancy can carry kind of significant morbidity, mortality. The data is a little bit mixed, but we think that this is about third in terms of maternal morbidity and mortality worldwide, kind of depending on the region. Preeclampsia is very severe. I've really only ever seen eclampsia once or twice. It's pretty uncommon in the United States. I know it's probably more common in Tanzania, and you guys see it more frequently. That you'd probably be more adequate in terms of treating it and recognizing it. It's defined as a systolic blood pressure over 160 or a diastolic blood pressure over 110. Eclampsia is always with a seizure. If they have a dega, then that's eclampsia by definition. Um, and it has to occur in a woman who is usually over 20 weeks for preeclampsia, but 34 weeks is um, the highest risk period. Definitive treatment is always delivery. These women go for cesarean section in terms of trying to temporize them so that they're stable for delivery. Magnesium is given. Magnesium is only to stop recurrent seizures, though. You're not going to ever get any type of anti-seizure effect by giving magnesium to a patient who's otherwise seizing. Eclampsia does not ever cause status epilepticus, so they should just be sustained seizures. You want to control the airway and make sure that the airway is patent. Um, but magnesium is usually given to control any future seizures and to try to kind of get containment of the situation. Um, because if mom has recurrent seizures, then it can become life-threatening pretty quickly. So, the standard practice is to give 4 to 6 grams over the first 20 minutes. A lot of algorithms mention doing this IM or IV. Um, I would say that, giving 4 to 6 grams of magnesium IV is stressful even in the United States, mostly because most formulations of magnesium are in large bags. So it's a lot of volume to give. I have given IM magnesium once for this indication. And it was very, very stressful and a lot of volume. After that's done, then usually you want to make sure that they're hooked up with a couple grams of magnesium per hour for the first 24 hours. You want to remember this is more of a deal in the United States, but patients who are obese can have subtherapeutic serum magnesium levels after treatment just because of sequestration of the magnesium. And you want to give on the higher limit if they're bigger. So give 6 or 2 grams if they're obese. The antihypertensives that we use in maternal hypertension, labetalol, nifedipine, um, and hydralazine. And you want to target a blood pressure under 140 systolic. If you have a mother who is seizing, there are a couple things to keep in mind. I would kind of remember it as like a common reminder in terms of just treating a patient with seizure. A, B, C, D, G. You want to make sure that you're checking the airway. You want to make sure that the patient is breathing adequately. The most important vital sign for a seizing patient is the SpO2. Patients die from hypoxia from seizures. And you want to make sure that you check a blood glucose for all those patients. and that you also control any airway um, concerns by just manipulating the airway as indicated or as needed. Lastly, kind of labor dystocia syndromes. You guys are probably more experts on this than I am. I'm not really qualified to talk too much about this. I don't deliver babies very regularly. I do deliver the occasional ER baby in the United States. I will tell you that what I know of delivering babies is that the McRoberts maneuver is the first manual maneuver in order to treat labor dystocia. And the two hallmark things to do when you're doing that is to apply suprapubic pressure and to create downward pressure on the actual baby's shoulder in order to allow delivery of the anterior shoulder. Um, if you're having issues with this, I've never had to do this as somebody who doesn't routinely deliver babies, but you can deliver the posterior shoulder. You also want to make sure that you ask mom to stop pushing while you do this so that you can kind of situate mom's legs into that high position. Make sure that the legs are kind of as flexed as humanly possible to allow to open the pelvis a little bit. Um, if you notice that this has not been successful, then I would recommend repositioning mom in order to try to actually get mom in the best possible state to actually try to deliver the shoulder and to avoid other maneuvers. And if you still can't do this, then, attempting delivery of the posterior shoulder is possibly indicated. There are other things that you can do that I'm not qualified to teach you or talk to you about because I've never done them before. But you can break clavicles. You can ask mom to go prone or go on all fours. And then there's a maneuver where you can push the baby back into the uterus and deliver via cesarean section. Um, at this point, even myself in the United States, I would certainly recommend getting an obstetrician involved. Um, what I will say, I don't actually know if you guys do this in Tanzania, but if mom has a certain shape of the pelvis or the baby's estimated weight is really high, the mom has, gestational diabetes, which is a risk factor for labor dystocia syndromes. Some of these deliveries will actually occur in the OR in the United States, specifically because they're actually concerned about a possible labor dystocia. Um, and there are certain algorithms in the United States that I know that actually go straight to cesarean section, even though we want to avoid cesarean section in a lot of moms for fetal outcomes. Um, for babies who are big enough, if the baby is large enough, then um, sometimes American obstetricians will actually just recommend a cesarean section just because of the high risk of labor dystocia. So, I forgot we had a slide on this. Yes. So, in addition to labor dystocia, something that's a little bit more rare, but definitely something that you want to consider about is pulmonary embolism and amniotic fluid embolism, or VTE or AFE, respectively. Um, Amniotic fluid embolism is pretty rare. It's pretty scary. I have seen it before. It is something that is commonly associated with DIC. These patients get acute right-sided pulmonary hypertension and can get right ventricular failure. Both can cause similar syndromes, but they're treated differently. In the United States, they're differentiated based off of CT scans and angiography studies. Even then, though, amniotic fluid embolisms, I'm sorry, amniotic fluid embolisms can be associated with VTEs, but AFEs usually carry a higher morbidity mortality than PEs. Um, there is no consensus on treatment in terms of AFE. Really, the big thing to remember is to limit volume. And this is the one circumstance to use vasopressors. You really have to have a good circumstance in order to actually do this instead of bleeding. Usually, mom would arrest, before she delivers or as soon as she delivers, um, and probably hasn't lost enough circulating volume in order to do this. I would say that, in my limited experience, I would reach for an ultrasound in order to confirm this diagnosis, specifically looking at the right ventricle, um, in order to kind of confirm whether or not I wanted to start vasopressors in this setting. Most of the time, I'm going to be transfusing a mom if I'm concerned about her. Um, for AFE, there's limited data on this because it is kind of a rare condition, but ECMO, inotropes, and pulmonary vasodilators are things that, if you have access to, have shown to decrease morbidity and mortality, at least from the limited data sets in the United States and in Europe. Um, Pulmonary embolism, the one thing to remember for these is that warfarin and DOACs are contraindicated in pregnancy. So usually the treatment is low weight molecular heparin and unfractionated heparin. Um, I don't know how many of you have thrombolized a patient with a massive PE, but it does work. Um, Sometimes, there's limited data on this, but for pulmonary embolism in patients in the United States, thrombolytics actually has some benefit for patients who have submassive PEs. In pregnant patients, all the guidelines say you have to have like a life threatening pulmonary embolism in order to consider a thrombolysis, just because they're at such high risk for bleeding. So really, only if their blood pressure is sustained, their systolic blood pressure is sustained under 90, even after a fluid bolus, and or you're doing chest compressions on them. So the two circumstances, they have obstructive shock or they have cardiac arrest. There's also a lot of data about not a lot of data. There's limited data, but there is some suggestions about surgical embolectomy. I've heard stories about people doing this in South Africa. I've heard zero stories about people doing this in Tanzania. But it's a possibility in high risk bleeding patients, and low resource setting. It's kind of a Hail Mary, if you will. The highest risk for clots is actually 2 weeks after the delivery. That's when most of the clotting factors are kind of returning to their normalcy. So, talking about all this, I will say that my role in obstetrics is extremely limited, and usually I'll be the first to say when, something in acute care can actually change a life. I think most things in obstetrics really come down to routine care. Um, One thing that I will, harp on is saving the baby in the first 5 to 10 minutes of the life is actually probably more important um, than anything you can potentially do for mom. Um, just make sure that you know your neonatal skills. If you're delivering babies regularly, that you have the ability to take care of that. In the United States, it's a little bit different resource allocation. Obstetricians are not taught how to actually resuscitate babies, and usually have no prior pediatric experience. As an ER doctor who sees one, sees all. Um, I would say that I'm a little bit more concerned about taking care of the baby than I am taking care of the mom. Um, Once the baby's born, just make sure that you calculate an APGAR. Make sure that you look at their appearance, what their color is. You listen to their pulse, or you get them hooked up with a pulse ox. You stimulate them and see if they actually respond to your stimulus. See what their activity is in terms of their tone, and see how quickly they're breathing. Once you have an APGAR, this is a score from 0 to 10. Uh, you want to see kind of what they're actually doing. If it's low, a low APGAR is usually considered less than 6, or it's, high. Things differ. If it's 8, 9, or 10, you can probably talk about doing a delayed cord clamping, making sure that you milk the cord a little bit, versus immediate cord cutting. If you cut the cord, make sure that you use chlorhexidine to sterilize it or to antiseptic. If you're doing immediate cord cutting, you want to make sure that you do resuscitative maneuvers. You want to make sure that you know, position the baby a little bit, clear the secretion, stimulate the baby. If the baby is apneic or has poor inspiratory effort, then you want to make sure that you give a little bit of positive pressure ventilation. If they're still not doing anything after cleaning secretions, chest compressions are usually indicated. If you're uh, still not getting anything after positive pressure ventilation, um, of the heart rate needs to be above 60 after 30 seconds. Usually a heart rate above 100 is considered normal, but 60 is kind of the threshold for chest compressions in the neonatal period. If you're unfortunate enough to have to do chest compressions, remember that the two medicines that are shown to have benefit is a bolus of NS, 20 milliliter per kg, sorry, not milligram, and then epinephrine. Most US guidelines suggest discontinuing chest compressions after 20 minutes, um, if the baby doesn't have any return of spontaneous circulation. So once mother has given birth, baby is okay. You want to make sure that you're checking blood pressures. Most of the guidelines suggest a heart rate every 1 hour, and then blood pressure every 4 hours. I would say blood pressure, I would maybe suggest more frequent than this if you're concerned. If it's a high risk pregnancy, then maybe Q2, or maybe even Q1 with a pulse rate. But making sure that those are documented in order to have kind of an adequate concern, document blood loss. Um, Hypertension can commonly be seen in labor. So can leukocytosis. We already talked a little bit about this. Um, the WHO talks a lot about cartography. It's not something that like I'm super familiar with, but this is just basically fecal heart tones and tachometry. I don't know if you guys are doing this over in L&D, but um, it's just one of those things that needs to be done. I won't talk much more about that because it's getting outside my scope real quickly. Um, yeah, and we already talked about weighing any pads. Um, when you discharge a patient from an acute care setting or L&D, uh, you know, I already say this. It's just like this is kind of starting to get outside of acute care, but thinking as a generalist, making sure that you're monitoring blood pressure, you're monitoring bleeding, in the postpartum setting, you're encouraging breastfeeding because it's good for mom, good for baby. You're making sure that the perineum is evaluated frequently, especially if there's at least a grade 2 or grade 3 tear, because those have a higher incidence of infection. So making sure that you evaluate them. Early mobilization for mom has shown to decrease PE rates. And then once mom discharges from the hospital, make sure that she has adequate information and understanding regarding any symptoms that are red flags, headache, bleeding, fever, things like that. There's also a guideline from the WHO about folic acid and iron. Um, this is again not something that I have done or thought about, but when researching this lecture topic, that was something that I personally learned. I don't know how many people are doing that, but you want to make sure that you do that for 3 months. So, just to reharp on bleeding, in the United States, we do what's called one-to-one transfusion. We talked a little bit about this in the trauma lecture. If you have whole blood and whole blood is more available, then do whole blood. Making sure you stop the bleed. Stopping the bleed is important. You can't take care of a bleeding patient unless you get source control over the bleeding. The best way to do this is uterine massage. If you're going to be transfusing a patient, make sure that you give a TXA. And then if the patient's unstable, do a quick fast exam. Take a look at baby. Take a look at the rest of the internal organs really quickly, in order to make sure that there's no intraperitoneal blood. Um, in the United States, we also talk a lot about DIC. Moms are at higher risk for DIC because fibrinogen is kind of a limiting factor when you're talking about clotting. So when mom has a delivery, fibrinogen is used a little bit more rapidly than other patient populations and in other conditions. Uh, in the United States, we check levels of fibrinogen frequently, and we also give something called prior precipitate and prothrombin complex concentrate, or PCC. So make sure that you reach for those if those are available. Quick overview discussion. We didn't discuss surviving sepsis in the last lecture, but we have talked about it before. Limit the fluids that you give to mom. Treat gram-negative infections with beta-lactams. Add metronidazole and azithromycin if you need to. In order to prevent, the WHO has several guidelines regarding anti or hand hygiene. There's a lot of discussion about antiseptic use of the vaginal or cesarean area before and during birth. Intrapartum azithromycin for vaginal deliveries, cefazolin for cesarean sections. You want to make sure that any perineal lacerations are closed because those can get affected if they're left open. Um, Make sure that you place chlorhexidine over the cord before cutting it to prevent fetal infection and ophthalmitis. And you want to make sure that you evaluate for retained products of conception and routine perineal checks after a high risk or high pressure vaginal delivery. So when you talk about kind of peripartum sick patients, and you're talking about interventions that can potentially save lives, remember the McRoberts maneuver? I don't know what you guys call it in Tanzania, but just make sure that you're remembering that feet go up, knees are flexed to the head, and then there's suprapubic pressure. I have heard an obstetrician say before that they have never seen this not actually work when done properly, and that this is the only maneuver that you ever really need in order to treat a labor dystocia. I kind of believe that, honestly. Most people in the United States deliver babies this way anyways. But you want to make sure that you're really exaggerating the movements, that the knees go backwards, and that there's pressure down onto the head and down onto the shoulder, not the head, in order to push that shoulder forward, and ask mom to stop pushing so that you can situate these maneuvers. If you're ever unfortunate enough to have to care for a patient who's died in front of you and is gravid, do a resuscitative hysterotomy. The most benefit has been shown within the first 5 minutes of cardiac arrest. This can be hard, obviously, and usually something that's just assumed to be done immediately. It's a pretty straightforward procedure. Cut vertically through a laparotomy, find the uterus, cut the uterus vertically, deliver baby, try to offload, and then stop any localized bleeding. Remember, in patients who are seizing or who are unstable, the airway is of concern. We're not going to talk about intubation, but you want to make sure that you take care of mom's airway. Mom's airway might be a little bit more edematous, might be a little bit more fatty, might be a little bit more anterior than your usual airway. When you're talking about, specifically doing chest compressions, we already talked about this, but just make sure that you remember that you want to kind of offload mom a little bit. So put a wedge in between mom. After you've delivered the baby, make sure that you laterally displace the uterus off the greater vessels. You may want to make sure that you go towards mom's left because the IVC runs on the right? So making sure that you're on mom's left side of the bed. that you're laterally displacing it towards mom's left, to allow the IVC to return blood. Once mom's given birth, uterine massage can be done one of two ways. I would say this is the preferred way, um, mostly because it's less invasive. The bottom left is the second way that you can do this. This was clearly invented by a man because it looks extremely uncomfortable. I would say only do this in circumstances where mom is bleeding a lot. If uterine massage still doesn't work, then you can place what's called a Blocker balloon. It's a pretty straightforward procedure. You have to use a speculum in order to visualize the cervix. I've seen obstetricians place it blindly without doing that, but I would say that, in terms of wanting to try to keep the field as clean as possible, I would use a speculum. Um, in order to make sure that I can actually pass the Bakri balloon through the cervix as somebody who doesn't necessarily do obstetric procedures very frequently. This patient also gets antibiotics because of the risk for infection. So third generation cephalosporin and plus or minus azithromycin. um, and then treatment of perineal lacerations. You guys probably do this more than I do, so I won't even talk about it. You're the experts in that regard. So, there are a lot of things in terms of harm prevention with obstetrics. Just making sure that you're emphasizing to your patients about prenatal vitamins, screening for STDs, GBS testing, um, routine blood checks, routine diabetes checks. I'm going to circle the ones that I think are actually the most important. Um, hand hygiene. It's hard to say that hand hygiene isn't important, but um, you know, those things are kind of the most important in terms of STD checking, BP checking, diabetes screening, and then just overall taking care of mom. Returning to the case that we had before, this was a completely uneventful delivery. Mom did fine. I pulled the placenta out. It was removed without much difficulty. There was a little bit of uterine massage that was done. Bleeding was well controlled. Mom did not have a substantial laceration that was causing any substantial bleeding, and it was left alone. Uh, Baby ended up requiring a little bit of CPAP, and mom and baby discharged after day 2. So, bleeding, infection, blood pressure checks. Um, Make sure that when these patients leave the hospital, that they have good return precautions specifically for infection. Um, what you can do outside of being a doctor is also just make sure that you donate blood. For those of you who know Dr. Swanson, I've heard him talk a lot about the work that Save the Children has done in Tanzania. I've never personally worked with them, but I know that they do a lot of important work globally. They do neonatal resuscitative courses, I think. Correct me if I'm wrong, any one of you, but those are always options if you ever feel concerned about taking care of babies specifically. Um, as always, the lectures can be accessed on KOPI's site. If you don't have this link, please let me know and I can send it to you. I'm going to put the slides and the recorded lectures up on the website later today. Later today, meaning my today, not your today. It's still morning time over here in the States. The next topic we're going to talk about, it's going to be a little bit of a longer topic because it's a kind of an extensive topic. We're going to talk about ultrasound. And this is going to be later in July. We'll try and do it the same time for you guys. I will be in Arusha for a couple of weeks, Arusha and Moshi, both at ALMC and at KCMC. So I hope to see some of you guys there. We will try to arrange a time to do an in-person lecture. I'm going to ask Clement, Dr. Ari Clement is going to help me a little bit with this, and we'll try and find an ultrasound machine, and we'll do a couple of scan shifts or scans on some people in order to try to kind of get a little bit more comfortable with the machines so that you guys can actually see how the machines work, because I know that when I was working at Celiani, there were a lot of questions about ultrasound. So if we can just try and take a couple hours to actually do some of the things, hopefully maybe you guys could feel a little bit better about it. Um, so that'll be the next talk. It's always a pleasure. I'm going to stop the recording now and we can take any questions.